this overview, if you will, of insurance. And there's so many different things that we can address here. But I thought that I would start off by talking about really that there's different types of plans out there, as well as different categories. There's also different types of financial assistance programs. We want to talk about some of those. And we also want to talk about policy considerations, which is where Jim is going to help us out especially. One of the things that I think is important to understand about health insurance is that the health insurance industry, if you will, or health expenditure in the United States is valued roughly at $3.6 trillion as of 2018. We've seen a consistent increase in spending in healthcare to the tune of anywhere between 3 to 4% increase year over year. And I'll be honest, I think that those things are conservative as we continue into more high cost medications overall. This is a huge part of the American expenditure. And I think that you're going to continue to see a lot of attention in this area. One of the things that really shifted things for our community, especially, and anyone who's impacted by chronic illness or rare disease, was the Affordable Health Care Act, which was put in place in March of 2010. All of us remember that date, and it was really quite a landmark moment. The marketplace is still open and has a lot of accessibility there, although the fundamentals of what made the marketplace what it was has changed drastically. I would also say that the expense and out-of-pocket cost of the plans that are available on the marketplace have really changed significantly as well. Inflation there has been rampant, and I'm not going to get into too much of the details there, but just know that the marketplace obviously is a core place that a lot of people are able to get access to individual policies, and has really made healthcare accessible for a lot of us in the rare disease community, especially. Three types of plans, though. There's beyond just the marketplace. There's also employer-sponsored plans, which are still running strong. That still covers the majority of citizens in the U.S. And then really there is really what's probably about 44% of the total community or population is already on some type of a qualified plan, whether that be Medicaid or Medicare, and the various types there. So talk about marketplace just briefly. This is really something, if you're not familiar, if you're on an employer plan and you don't have to get into the weeds of the marketplace, I'll just give you a quick overview of that. It's available based upon your county or maybe your location. So you start with your zip code and you put in the information on healthcare.gov to kind of find out what plans are available. When things first started, there was a tremendous amount of competition, and pretty much everybody that was in health insurance at the time participated. And we even saw in some markets where a lot of people started issuing health insurance that were not previously very active in the health insurance market became active when the marketplace was launched. Since that time, we have steadily seen, I don't even know if steadily is the right word there, but we've seen a decline in participation in the marketplace from insurance companies. And today, there are a lot of markets across the country where there may only be one or two policies available in your specific area in the marketplace. Something else that we've seen change quite a bit is the pricing structure. Originally, there was also it was quite a bit value for the dollar amount of what you were spending in premiums. Today, that is simply not the case. You're seeing extremely expensive cost monthly for individuals and for families for much less benefits. For the few places. And we think some of that's just because of lack of competition that's been in the in the marketplace itself. This is all accessible, obviously, on healthcare.gov, and you can learn a lot more specifics about your area by going to that website and digging into it, which is how you apply for it. And then one of the big benefits about using the marketplace still is that there are potentially government subsidies available based upon your income level, where you may be able to qualify for some access to, you know, the government being able to help to supplement those premiums. So you may get a total out-of-pocket premium cost, and then you may qualify for a subsidy where it reduces your out-of-pocket cost to, say, $700 a month. And so that can be something that's a real value to being able to go to the marketplace. Another place you can go to get individual plans is to the insurer directly. So sometimes you can go and get from a Blue Cross or from another agency, you can go and get a health insurance plan that's not in the marketplace, but it's still available to you individually. It's just more difficult to get the subsidies that way. So if you're looking for a subsidy, the best way to do that is to go through the marketplace. Good. The other type of plan, and I didn't mention this at the front end, but if you have any questions, it's really a great idea to go ahead and put those questions in the chat section, and Aaron and Amanda will help me field some of those questions a little bit later. But if you have questions, go ahead and type those in, or if you want to just hold them, we'll definitely be answering some questions on these things as we go towards the end of the session. The next type of plan is employer-sponsored plans. Many people are familiar with this. Employee-sponsored plans are still alive and well and thriving, although we've seen, again, a rise in cost both to the employer and to the individual. The availability of these types of plans is strictly based upon who you work for and what they chose to decide to give you in terms of those benefits. The way that you apply is generally through your employer's HR department. And sometimes there's a waiting period. So you may start to go to work for, say, Toyota, and then 6 months later be eligible for that insurance plan. Every company has to decide those waiting periods, and sometimes they go from anything from no waiting period all the way to sometimes a year before you become eligible for those health insurance plans. Subsidies sometimes within those types of structures are often offered by the employer. So you may pay a portion and your employer is paying another portion, but those things are often, again, determined by the employer. We are starting to see some employers get down to where they're nil, to in some rare cases, even seeing some employers not offering any subsidy to help. And that's just because, again, the rising costs of these plans is just continuing to really eat away at the erode, you know, some of the feasibility for these companies to offer these types of structures. And the last type is probably one that we're all familiar with, which is qualified plans, Medicaid, Medicare. There's different ways to access this, but the Medicaid is managed through the state. As well, Medicare is eligible through either your age or your long-term disability, if you have that. And so Social Security disability oftentimes automatically will provide you with Medicaid in your state. You would just need to go to your state Medicaid office to be able to apply for that. A lot of times you can just Google it and find a state Medicaid office that you can apply for in your state. Each one is named a little bit differently, so you can't really just say this is what it's called every time. It's usually something Medicaid office. So that's how you get to those. And the people who are eligible for those are listed here on this slide. It's adults with low income, children, pregnant women, people who are age 65 or over, people with disabilities, long-term or short-term, depending upon what you're applying for. So those are the different types of plans that are really that you might hear of or see, or even have to be on at different times in your life based upon your status. I want to talk a little bit about assistance programs, because this is where we start to get into really the weeds of where a lot of the upcoming policy issues are. This is where there's been a lot of challenges, and especially with charitable assistance programs. But first, I want to talk about what those programs look like and what they are, and maybe some grouped information here. There's three primary types of assistance. There's copay assistance programs, there is health insurance premium assistance programs, and compassionate product programs. Real simply, copay assistance can be anything from helping you cover, they usually give you a coupon card, or they give you some type of way to be able to present at the doctor's office when you're going in, and you might have a $25 copay. That copay assistance can help you to be able to cover that $25, or it can even reduce the cost of your out-of-pocket expense if you're going to get a prescription filled at the pharmacy. These types of programs can often help with deductibles. There's been an enormous increase in high deductible plans that have come around, where you have an out-of-pocket expense that you have to meet prior to you getting 100% of your coverage met through your policy. So for instance, a lot of plans today may have a $5,000 or a $10,000. We've seen them as high as $15,000 or $20,000 per family, where you really have to hit that number before there's no copay or no out-of-pocket expense. Copay assistance programs can help with this. So in the bleeding disorders community especially, we see where there are a lot of programs available where they can help you not only with that $25 copay at the doctor's office, but also with the deductible. And in some cases, I've heard people refer to this as sort of the silver lining with having a rare or high cost medication requirement. And that is that it really can help you if you have a high deductible plan. Talk about premium assistance a little bit. That has been an area that many people are familiar with. Jim Romano, of course, has been with PSI for a long time, 15 years. How many?
Yeah, 15.
15, yeah.
Yes.
So PSI was one of the first organizations that ever created this model of really premium assistance and helping people financially by paying their monthly premiums when they were having difficulty because of a chronic illness. And so, matter of fact, the founder of this idea and concept is here on the call with us today, Dr. Dana Kuhn, and it's good to see you, Dana. Thanks for being with us. This is an incredible size market now, where there's a lot of different organizations that help in this space. It's been under a lot of attack in the past few years, and we'll talk about that in a minute. But premium assistance is not the same as copay, because premium is going to help you with that monthly cost, whether it's temporarily or it's maybe on an ongoing basis, but it can help you with the monthly expense. That can be done whether it's an employer plan or if it's a sometimes an individual plan, but there are a lot of limitations on the qualified plans. So in some cases it can help if it's Medicare, but again, limitations there. So it's worth looking into, but especially on the individual plans and even employer plans, that's a place that you can get assistance.
Hey, Jonathan, can I jump in real quick?
Absolutely, please do.
At PSI, and I agree with you, it's always interesting to give a presentation about insurance in PSI when the founder of PSI is on watching. However, PSI does help with a number of different plans. So not only do we do commercial insurance with marketplace, employer sponsored, or any other commercial plans, but we do help with Medicare Part D. I know that's not exactly a large amount for the hemophilia community, but we do help people with their Medicare Part D plans, and specifically Medicare Part B plans. So you're helping with your wraparound coverage and your Medigap plans in states that offer them to the under 65 disabled population and the over 65 population. So it's not just like when people think of premium assistance, they think of, okay, I have an Obamacare plan or my employer sponsored insurance. When there are quite a few Medicare Medigap plans that we help patients with. We also help with in the past with GHPP in California, which is a Medicaid plan. So I always say when it comes to premium assistance, call PSI and we'll answer your questions for you.
That's great, Jim. I appreciate that. You guys really are the experts on this thing, and especially when it comes to each individual program has its own nuances. So really important to investigate where you think you may need help, because your situation or your state or your plan may be entire. I guaranteed it's unique. So it's very individualized. The third type of assistance that you might be able to find is compassionate product programs. This is a part of the community that I think is underutilized, but it definitely is something that when it's needed, it is critical. And so I do think that people have been able to take advantage of these types of programs in life-saving ways. This would be where if you lose your insurance for some reason and you cannot get into another policy immediately, let's say, for instance, you lost your plan and it's not open enrollment is not available for another month or two, a compassionate product program would be where you may contact the manufacturer of the drug that you take this from, and they may be able to have a program available to where they can send you the medication free of charge, and it would not go through your insurance. So if you ever find yourself in a situation where you are just in a lurch, you lost your health insurance for whatever reason, God forbid, I think that compassionate programs are there to help you bridge that gap. One interesting thing to note about these programs is that they often cannot help if you were previously on a qualified plan. So if you were on a Medicaid or Medicare plan previously, they really very few of them can even help you there. But if you're on a individual plan or an employee sponsored plan, oftentimes they can help you be able to get that product if you need it. So hopefully that helps you, give you some overview. Talk about premium assistance a little bit. In the health insurance premium world, these types of programs are critical. There are a lot of organizations that provide premium assistance for different disease states. So you can Google it, or you can just call Jim or call me or call somebody, and we'd be happy to give you the right place to go. But there are a lot of organizations out there that provide assistance. PSI obviously is the oldest and one of the larger organizations that does this work specifically, especially for hemophilia, and really have a tremendous team over there of experts. We do a little bit in the hemophilia community to help bridge the gap if there's a need there. But there's some other organizations here that don't all help with hemophilia, but you can investigate each one of those individually as well. Many of these organizations are also part of a coalition now that Jim really helped to spearhead a few years ago, that we've lovingly referred to as the United for Charitable Assistance Coalition. And this is something that Jim will talk about a little bit later, but we're really working together to try to help bring a unified voice to policy initiatives as it pertains to this type of really critical care. So I want to dive a little bit into policy issues. Obviously, everything that we just talked about, we could probably spend a whole meeting on each one of those sections. So there may be lots of questions. Feel free to put that in there if you have questions in the chat. But I want to talk about three specific areas that we see are problematic for anyone living with a rare or chronic illness that may be dependent upon high-cost medications. And the three issues that seem to continually come up, and there's more than this, but these are just sort of the top ones, is accumulator adjuster, which you may or may not have heard of or may be familiar with, but we'll talk about that a little bit. Step therapy is an interesting dynamic where basically you're trying to eliminate certain drugs before you go to maybe a newer or higher cost medication. And then, of course, the PBM mandates that we see that are so rampant throughout the community now, and I think will continue to see be problematic in some ways. So, I want to talk about these three things separately. And Jim, feel free to dive in here anywhere that you want to help out with here. But the first thing that I wanted to talk about was the accumulator adjuster. I am not the country's foremost expert on this, but I can tell you what I know. First of all, the accumulator adjuster is an attempt for really all of these things are an attempt to put back in place a lot of the restrictions that we had seen once upon a time, such as with lifetime caps, or you may have seen pre-existing conditions. These are all mechanisms that insurance companies are using to sort of prevent people from getting the care that they need. The accumulator adjuster was created largely because we had these assistance programs that were able to help with copays and deductibles. So it became probably more of an issue with deductibles than even just the copay. But this is the concept, is that it prevents any copayment assistance that may be available for a high cost specialty drug from counting towards a member deductible or maximum out of pocket expense. And so it's just a way to sort of say, well, you get $15,000 of support because you're on a particular medication and there's a program available for that, but we're only going to allow $3,000 of that to be applied to your deductible. We've even seen them before where they didn't allow any of it to be because it was coming from a third party. So it's really unfortunate, but that is a huge. It's becoming a higher and higher problem, more common problem, I should say, throughout the community.
So Jonathan, thank you. I would also step in here and say this started. Insurance providers are always going to look for a way of passing more of the costs of care onto individuals, especially patients with rare and chronic conditions like hemophilia. This started, as interestingly enough, in the self-insured markets. So with employers wondering how they could save costs. And that's where they had made the decision that copay cards issued by manufacturers would be accepted, but not counted towards the out-of-pocket limit. And so for a rare disease and a chronically ill patient, that has a lot of consequences. So yes, they can get their drug. The problem is that then if you're not really satisfying the out-of-pocket level, you're going to pay additionally when you go for different, major medical or in your drug costs for other treatments or ancillary supplies and such. So that's what makes the accumulator such a pernicious issue. And I want to, give a shout out to NHF, especially Colette Colianos. She has done yeoman's work on this issue, both federally and in the states. She's a nationally recognized authority on this issue, and I'm really, happy she's a friend of mine. So whenever I have an accumulator issue, I do pick up the phone and call Colette over at NHF. But it's very interesting. Insurance mostly is regulated on the state level, and Dana Kuhn used to always, we would go back and forth when we were debating policy, and he'd always say, Jim, McCarran-Ferguson, which was a bill that was passed actually during World War II, set the regulation of insurance, health insurance, on the state level. Now you have ERISA, which does for the self-insured plans, which is more of a federal program, and now you have the ACA, which is federal regulation. However, when it comes to accumulators, you can attack these on a state level for plans that are regulated in that state, and you've seen that in Arizona, Virginia, West Virginia, and some other states that have banned the concept of or made sure that copay cards and copay assistance accounts out-of-pocket expenses. I know Kentucky's about to introduce a bill in their next legislative session. Sue Martin in South Carolina has been working on the issue to try to, so you can, the hemophilia community is very organized in fighting accumulators on a state level when partnering with other groups. And there has been some federal legislation that has been introduced, and basically a bill that would overturn a rule. So initially this was being handled through rulemaking process through CMS. And originally the rule that was put out basically was going to put a pause on accumulator programs. And then when the final rules, that was like a interim rule. And then when the final rule came out, that was removed. So legislation, and actually Richmond Congressman Donald McEachin from Virginia has introduced legislation with Brett Guthrie, a Republican of Kentucky, to put a pause on that federal rule. So, so there are some federal and state advocacy groups really working to move this issue forward.
That's great, Jim. Thank you. I would say also the accumulator issue is difficult. We've actually heard from several patient families over the past year or so where it stopped them from being able to order more factor because they literally couldn't do it without having to come out of pocket, sometimes tens of thousands of dollars, and just flat couldn't do it. Other people have filed bankruptcy. So this is an issue that I think we absolutely need to address, and we're doing what we can to be able to work together to continue to bring attention to this issue and try to fix some of these loopholes that have happened. Good. Third-party premium payments is a major issue that that has really started to develop, and you may or may not be familiar with this issue. But if you have benefited from receiving assistance from an organization like PSI or Hope or maybe other organizations that are out there, you may have. This is where an insurance company is basically saying, we no longer want to receive a premium payment on behalf of a member from a third party organization. That could be a PSI, it could be Hope, it could be your local church, it could be a civic organization. They are not going to allow, in some cases, those payments to be made. Now, this doesn't apply to all insurance companies, but we are seeing this language getting put into more and more contracts, which really was initiated by a move from CMS to say that any marketplace policy was not required to accept a third-party payment. And in the past, it had been a process that had been acknowledged, and really no one had ever challenged it before. And so this became a problem when they issued their letter. But really, we started to see last year quite a few insurance companies start to include this rejection of third-party premium payments, and then we've seen them take action on that as well. Jim, would you like to address anything on the third party?
Yes, my wife says I talk about this in my sleep, which is true. So in 2014, CMS, as the exchanges were coming on to the online, issued this interim final rule. And the rule was very specific, actually. It said, if you are a plan operating in the state or federal exchanges, you had to accept third-party premium assistance from 3 specific entities. The first was the state Ryan White program. That was in response to actually to Blue Cross Blue Shield of Louisiana saying they weren't going to accept Ryan White dollars. So the Ryan White HIV program, you have to accept if you're a plan. The second was Indian tribes, urban Indian tribes, or the Indian Health Service. And then finally, typical of the government, they put a total blanket. You have to accept it from any other government assistance program. So like Title V is an example of that. At which point they also put into this rule that, and anybody who knows me knows, I talk about this all the time. they said that you could, but you could have a prohibition against any other entities. So you have for-profit entities such as manufacturers, but that also includes obviously nonprofits and any kind of other organization, like the Farm Bureau is an example, or my Roman Catholic Church, or the Lions Club, or St. Jude's Hospital, or the Shriners. God, the Shriners ads make me cry when I watch those on television. My point is, they really are cutting a hole in the social safety net. We've been fighting this at PSI now for 6 years. We found a champion in Senator Kevin Kramer of North Dakota. In previous Congresses, we've had introductions of legislation because of, I think, from Jim Romano's perspective, when Kevin Kramer moved to the Senate, it kind of slowed down, introduction, I think, as he's getting used to the Senate. So we're in talks, in the final talks with him, of introducing a bill come early in the next Congress. And actually, if you don't mind me talking about this, Jonathan, using the results from Tuesday to talk about legislation in the upcoming Congress, I really want to say is we're going to have a centrist Congress, I believe. And I know that sounds kind of interesting, but the way that the Senate's going to be pretty much the way it is now. The Democrats might gain a seat. And then in the House, the Democrats are going to have a reduced majority. But what I believe is, no, and you're going to have, we don't know how the presidential race is going to resolve itself. However, you're going to have a lot of people who are going to want to get some legislation done. And I think that a lot of the push on patient assistance programs is going to really lose steam in the next Congress. And I think that as advocates, we can really, at this point, take advantage of that once COVID is over and we actually can get back to Capitol Hill and promote patient assistance programs, because I think it's my hypothesis that the time has, moderates on both sides are going to be stepping up and wanting to discuss solutions for patients. And I think so the time is going to be right in the next Congress, starting in January, on really dealing with some of these issues. And that's why I'm really glad to be working with United for Charitable Assistance and building it up, because all of these issues are affecting patients. And we have an entity that's going to be built and that I'm going to be leading to really address the importance of charitable assistance. And I'm really proud Jonathan is on our executive team at UCA. So we're looking forward to working with Hope and on these issues, because all of these issues will fall under charitable assistance in the future.
Yeah, one major thing that that happened to us last year, and Jim, you might want to expound on this too, is that there was, I say last year, it's really 2 years ago, but it was an unfortunate thing that happened when we were really pushing the envelope on trying to make progress on this issue. And the insurance companies took the opportunity to try to publish some materials and really twist the story and their narrative to make it seem like it was the fault of these programs that made drug costs so high. And it simply isn't true. Matter of fact, you can go to quite, there's an abundance of information out there. But we were making some progress on getting this third party issue really to be put to bed in many ways, as it was starting to rise in the early part of the conversation. But because of this narrative that kind of came into flow, was that the insurance companies just simply have more money than we do to be able to advocate on the Hill. And so they can put a lot more energy in there that we just simply don't have. But our voice is powerful, and we've always done really well in this community, as all of you probably know, in advocating for blood safety and for the HIV cause, and so many other things. We've made huge headway in this area before, and I believe our voice is loud. We just need to be on the same page so that we all know what we're fighting for. And this third-party premium payment issue is going to really be a continued problem unless we have, some movement in this area. So, Jim, do you have anything else to add to that?
Well, yes. So there, PSI actually was talking with the House Oversight Committee, had a hearing right before the election, and patient assistance programs were discussed. And interestingly enough, one of the members from Michigan actually attacked Novartis regarding patient assistance programs, calling them a side hustle, which when you rely on these programs, what policymakers and the insurance company, what the insurance companies want to make sure policymakers don't understand is that patients rely on these programs. And it's our job to make sure that patient voice gets there. But we were actually used it to our advantage. Our new CEO has a great relationship with the ranking member, Congressman Comer from Kentucky. And we had a great conference call with him about this issue. And they're going to be doing more hearings, and PSI is putting out a white paper on patient assistance, and we'll be in the next couple of weeks, which we'll be submitting to Congressman Comer, really emphasizing the need of patients. So, we are not going to be taking this lying down anymore. And I think having a greater patient voice, as opposed to a patient assistance voice, is absolutely needed, because they can hear Jim Romano all day long talk about why we need to do this. But when you meet with your constituent and they say, listen, when you start messing with these programs, you're messing with my life, I think that's a powerful message.
That's right. I always say never underestimate the power of your story. And this is really what moves the needle on this. It's really the only thing that ever has moved the needle on these issues. And so I really just want to encourage you, when you have the opportunity, please take advantage of it to get your story out there, whether it be in a media form or a newspaper article, or with your local chapter, or a national movement, or if there's a Washington Days opportunity. Any of those things are really helpful. And we really need your help to get your story out, to talk about these issues. I want to touch on the other two things briefly. PBM monopoly. I put that on there largely because I think we're familiar with the idea that some insurance companies have their own pharmacies that are owned by the insurance company, that they're forcing people to use that as their only option to receive their specialty drugs. And one of the challenges with that is that it limits choice, and it's a big problem because some of these organizations are not experts on your specific disease state. So, for instance, you may need to get help with your hemophilia, but that particular specialty pharmacy may not even understand what hemophilia is, period. And you ask them for syringes or for needles, and they just delay the process of getting it to you and are not responsive when you need them to. Or if a prescription is changed to a different drug or to a different type of distribution, it may not happen accordingly. And those are things that we're seeing problematic. We have seen people suffer as a result of having people that are not experts in this area. It would be kind of like if I needed to get my transmission changed and I called Jim Romano and said, Jim, I need help with my transmission. He probably couldn't help me, but if I needed help with my health insurance, I'd want to make certain that I called Jim, because he might know a little bit more about that than transmission.
Ask you which end your transmission's in.
A last one issue I think that's worth us talking about is surprise billing. This is something that has become a little bit more of a topic, and I do believe that there's going to be some movement on this issue overall. But the concept here is that there's a lot of people who end up in an emergency, or they're in a surgery, or they're in a procedure, or they even could go to their treatment center and see one physician, and it's under their plan as an in-network person, but they see another person who walks into the room and it's an out of network person. This happened to us actually when we were having one of our children, and there was a emergency situation that happened, and they had a nurse run in to help assist, and this person was considered out of network, and it became a huge nightmare. We owed tens of thousands of dollars to be able to help to satisfy that, and it was a real nightmare. This is something that I think is probably low-hanging fruit that will be something we can move the needle on. But I do believe it's a problem that all of us need to be aware of. And so when I hear people, there's a lot of things that are said within the hemophilia community, especially that are talking about, well, we need to talk about unity, and we need to talk about events, and we need to talk about fundraising and all of these things, and they're good and they're important, and I'm not against any of this, and very much for all of that, as you can imagine. However, one thing that is important to me is that most of our community was founded on this idea that we could get on the same page to fight for the needs of our community members, fellow community members today and in the future, the next generation. And I don't see that same kind of unified push that we have had in our community in times past. And I truly believe that it will be to our detriment if we don't get on the same page about some of these things and really start working on the priorities that not only affect us now, but these things are only going to get worse. I mean, uh, we could talk about each one of these all day, and I could tell you some horror stories, but I'll refrain. I put this slide up really as a way to sort of help you understand. There's a question that comes up in all of this is sometimes, why would an insurance company want to harm people? Why would they want to put these mechanisms in place to bring difficulty to our lives? And why are we always fighting against them? And I just want to say this, many of you know I have a background in financial planning. And one of the things that is very, very common in terms of understanding how these companies manage a for-profit business entity. They are responsible to their shareholders for increasing their profitability. And so they are companies and businesses, and insurance companies, what they do for a living is they manage risk. Which means that they do everything they can to eliminate risk. Many people don't know this, but a small little factoid that you might be interested to know is that insurance companies as a whole, the category of insurance companies, actually in the US has more money on hand than banks do. And this is something that's really critical to understand, because when they talk about, well, we can't pay for it if this, or we can't do it if that, what they're really saying is they've been paying a 5% dividend. They've been increasing their profitability year over year, 12, 15%. They've been able to increase their portfolio, da, 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 da. And what they really mean is they cannot continue to do their own internal growth patterns. It doesn't mean that they're broke. It means that they actually, quite honestly, have more money than banks do. And so from this point of view, it's really important to understand that there are a lot of things that insurance companies do to continue to maintain that. And it is their job to limit their financial risk for shareholders. That is what they do, okay? Which includes health insurance. Now, as an individual person living with a rare chronic disease, my number one concern and thing that I have to be aware of is that I am not concerned about anyone else's financial risk. I'm concerned about managing my survivability. I am here to manage my life that's at risk. And there is a higher value on life than there is on money. And not everybody would even agree with that statement. And if you're talking about it from the management of a higher value on the thousands of people that are insured by these organizations. And I understand the arguments. I'm just trying to make the point that you need to have it as an advocate for yourself or for your kids or for your family members. You need to have it in your mindset. You understand that the number one critical thing here is that we advocate for people's lives. And the thing that we're going to be in constant sort of tug of war with, if you will, is a behemoth of an industry that has more money than banks do, that are trying to manage their risk. I don't necessarily blame them for that. I don't have any hard feelings for that. But that means that our voice has to be louder and has to be more with more conviction and has to be more focused, because our story is the only thing that's going to change this. And it's our lives that are at risk. It's our livelihood that's at risk.
Jonathan, can I jump in here?
Please.
I also, health insurance companies, I know there's a strain of thought of engaging them with discussions. Unfortunately, from my experience, there's always going to be a push and pull because as Jonathan said, they're trying to maximize their profit and do so by reducing their costs. And I totally understand that from a business perspective. However, they that a meeting with patients for legislators who are part of the regulation team is very important, and those stories are extremely important. But when you get, and it's going to take a lot of time and a lot of planning and a lot of keeping our cool, because if you go into a state legislature, the Banking and Insurance Committee, if you look, most of our state legislatures are part-time legislatures. Most of the people in the banking and insurance committees are insurance salesmen or work at, so it's always an interesting, task to go in and talk with them. However, in Virginia, we've had great success, especially in the last couple of years with advocates really changing the narrative. I'll leave one funny story. Dana and I were at a meeting of the National Conference of State Legislators, and we were at Virginia night with our legislators, and we were talking to this person, and this gentleman comes up, and we were talking when he asked what we did, and we told him we help sick patients, we raise private donations and help them pay their premiums, and he looks at us and goes, "My members hate you guys." And I could only look at Dana and say, usually it takes 10 minutes and not 5 minutes for people to say they hate us. But here he was the lobbyist for AHIP.
Oh gosh.
Okay, that's life.
Well, I think that it's interesting, and it's important for us to note that these are strategies. These things that we're bumping up against are strategies that they've used to limit their financial risk. And again, I don't necessarily blame them for that. It's not something that, but an appeal to humanity is about the only way that we're going to be able to navigate these things. And many years ago, we were all thankful for ACA when it went into place, because it eliminated lifetime caps. But why was lifetime caps put in place? Well, they said, well, basically, we don't care that you need to have $1 million a year. We're saying $1 million for your entire lifetime that you're going to. If you hit that $1 million thing, good luck. We don't care about your life. We're just not going to pay for it. That's what lifetime caps did. Well, pre-existing conditions was another part of that. Pre-existing conditions says that you can't get an individual policy unless you are a healthy person. Well, ACA changed some of that, but the dynamics that didn't help us is that now they've just gotten more creative and found out ways to be able to say, oh, well, charitable assistance is now making it possible for people to maintain their health insurance when they don't have. So we're going to put this accumulator in place. Oh, third-party premiums? Nope, let's get rid of that too. So the idea here is the strategy is really still the same, which is to get sick people off of insurance policies, because sick people are the reason why insurance does not make money. And it is going to be the only way that we can overcome this is by sharing our story, making our voices heard, being able to communicate, what our experiences are. You don't have to be a professional person that understands all the nuances of third-party premium payments and every single thing that goes on behind the doors. But you do have to be, your story of what has happened to you personally can really change the narrative for a lot of these decision makers. And so I think that that's really, really critical. I love this quote by Helen Keller, which is, alone we can do so little, but together we can do so much. And I really believe that these opportunities are things that are going to come up over and over and over again over the next probably number of years. until there's a solution that's put in place. But at the end of the day, we're doing what we can to try to advocate for these issues, because this is the difference between life and death for many of us. And it simply isn't that same problem on the other side. The other side of that conversation is, it's the difference between 7% profitability versus 5% profitability.